Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello and welcome to Always on EM, the Grand Rounds edition. We are broadcasting on National Pi Day for 314, or March 14th, 2025. This happens to be one of the nerdiest days of the year, as it is also Albert Einstein's birthday. He was born in 1879, and even before him, Dr. Ehrlich, of many medical discoveries and eponyms, was born on this day in 1854. Also sharing this special day, Johann Strauss, the gifted composer, was born. In true circle of life stuff, another renowned physicist, Stephen Hawking, died on this day in 2018. So, thank you for tuning in to our show today. Who am I? I am Venk Bellamkonda, or Venk like vancomycin, and I'm one of the two hosts of this show, along with the best host in the business, Dr. Alex Finch. And interestingly enough, I missed the cut of sharing this auspicious day ever so slightly, as I have the amazing March 13th birthday. Had it been one more day late, I probably could have been right there with Einstein and Hawking. I'm sure that's the only difference between us. Anyway, today, Alex and I thought it was only fitting, as it were, to share the reflections of one of our incredibly gifted faculty, Dr. Alex Ginsburg, with you all. He has been an outstanding colleague and brings harmony to disarray wherever he goes. He is like a theorem to explain the unexplained. We will jump into a more complete introduction momentarily, but if you could take this moment to like, follow, and comment about our show, it's really the best way you can say thank you to us or advocate for the work and really give back for anything positive that we might do for you. Okay, let's jump into the recording in 3, 2, 1. It is my extreme pleasure to introduce Dr. Alex Ginsburg as our speaker for Mayo Clinic Emergency Medicine Grand Rounds today. Dr. Ginsburg is a distinguished physician currently serving as Senior Associate Consultant and an Assistant Professor in the Department of Emergency Medicine and the section of Palliative Care here at Mayo Clinic in Rochester. Dr. Ginsburg's academic journey is unique and impressive and likely contributes to his very unique, grounded, and really helpful takes on life if you've ever had a chance to talk to him about conflicts you're having. He obtained a bachelor's degree in religious studies from Barrett Honors College of Arizona State University and a master's degree in geography, as well as a master's degree in community and regional planning from the University of Oregon. And then we were fortunate enough to begin our journey with Alex after that, as he joined Mayo Medical School and then graduated with his medical degree before joining our residency program and going on to serve as chief resident in his final year. After that, he continued on to do fellowship training at the University of Pittsburgh Medical Center, and his fellowship was in hospice and palliative medicine. He is board certified in emergency medicine and hospice and palliative medicine, and his teaching expertise is extensive, having served as instructor and coordinator for various courses and conferences at Mayo Clinic and abroad in emergency medicine, trauma, critical care, general surgery, lecture series even, palliative medicine, of course, both resident and faculty didactic programs. And he's been recognized for his medical education in various ways, including receiving awards such as Educator of the Quarter and the Research Innovation Award during his time in the residency. In addition to his teaching prowess, Dr. Ginsburg has a profound expertise in palliative care and has been actively involved in developing and delivering palliative care education, including courses on serious illness communication, pain management care education, and courses on end-of-life discussions. His research interests, as you might imagine, include palliative medicine in the emergency department and improving the efficiency in handoffs related to palliative care. These are all areas I personally really struggle with, and I'm sure many of us could all be better with. And so I'm really excited that you're talking with us today. And so thank you so much. Everyone, please join me in welcoming Dr. Alex Ginsburg as our speaker today.
Thank you, Venk. Thank you for the chance to speak at Grand Rounds today on integrating palliative care into the ED. All right, no disclosures. Learning objectives are at the end of this Grand Rounds. I'd like you to be able to explain the rationale for emergency medicine palliative integration, describe approaches to emergency medicine palliative integration, identify patients who need primary palliative care interventions in the ED, and apply specific skills to rapidly clarify goals of care in the ED. To give you some context about why I'm talking about this and specifically focusing on not burdening emergency medicine providers, I have to take you back to 2021. And I was a fellow in hospice and palliative medicine. And at the time, I thought that doing fellowship, I would come back and I would be like, we're going to bring all these things to have emergency medicine providers do. We're going to bring all these skills, do all of this training. I had a lot of ambitions about that. And that fall, about 3 years ago exactly, I was interviewing for this job that I have now. And I was interviewing with one of our colleagues, talking about these plans. And I was like, I want to have serious illness communication training for our staff. I want to get people to learn these skills. And our colleague very calmly said, I really don't think I could ask our staff to do that right now. And I was disappointed and I was sweating a little bit because I thought I'm not getting this job. But our colleague was right at a really good point, because fall of 2021, this is where we were. It was the Delta variant. We were overwhelmed with COVID in the midst of the pandemic. We had overworked providers. We were facing critically ill patients because of COVID or because of other conditions they weren't seeking care for. We were dealing with all of this PPE and wearing the same N95 for days on end. And we were adapting to all these new ways of life, right? 6 feet of distancing, no visitors, going through these weird drive-throughs to get your nose swabbed. And the only thing that really helped make it a little more bearable was occasionally we'd get recognized for the work that we were doing on the front lines. So thank goodness that's over and we're back to normal, except we're back to a new normal since the pandemic. And our work environment and our obligations as emergency medicine providers have changed. So now we're routinely facing 40, 50, 60 patients in the waiting room. We're seeing people in different care areas like the hallway. We have exit blocks, so we know what patients need and we know where they need to get to and we can't get them there. And some days it feels a little bit like a dumpster fire to be working in the emergency room. I appreciate the nod, Dylan. And at the same time, we're being asked to do more. We've got to learn TEE and maintain these skills. We've got to take care of these boarding patients and basically do internal medicine for hours on end, learning regional anesthesia. We're trying to get our telemedicine practice built up. And sometimes, not that infrequently, we have a critically ill patient in the emergency department. ICU is telling us, can't you just tune them up a little bit more and maybe they can go to the floor? So I want to be clear that not all of these things are bad. We need to expand our scope. We need to learn skills, but all of them are an ask. All of them are an obligation. All of them put strain on our workforce. And so many of us are feeling that we're pulled in too many directions. So what was true in 2021 when I was interviewing is still true now. We've got to be really thoughtful about what we're adding to the scope of emergency medicine. And we've got to think about how we're going to balance new initiatives, how we're going to balance bringing palliative care into the emergency department without overwhelming our providers. So that's what I want to talk about today. Is how do we do that? How do we create a system so that your shift doesn't feel overwhelming, you just have another obligation, and yet we can also bring needed care to our patients. Before getting into that, I want to make sure that we all start at the same page. I want to define palliative care, because some of you may feel really comfortable knowing what palliative care is, and some of you may be like, I kind of know, but I wouldn't want to have to be on the spot in defining it. In order to talk about what palliative care is, we have to talk about what palliative care is not, because I know there's somebody listening to this who hears palliative care. Oh, I got ahead of myself on my slides. If you don't know what palliative care is, you're in good company. 20% of PCPs think that palliative care is only appropriate for patients in the last 6 months of life. 29% think it's only, or think that it's the same thing as hospice care. If you don't want to be compared to a PCP oncologist, 30% of them don't think a patient can have palliative care and chemotherapy at the same time. So to define what palliative care is, we have to define what it's not. And somebody is thinking about this. I know it because I talk to people every day who talk about what palliative care is and their misconceptions. So there's some other things that palliative care is not. It's not geriatrics, although we care for a lot of older adults. It's not hospice, although that's a part of palliative care. I often hear providers say, well, the patient doesn't need palliative care, doesn't need goals of care because they're not ready to give up. Palliative care is not giving up. And it's also not doing nothing as opposed to doing everything. So what palliative care is care for patients with serious illness, including obviously cancer, but also stroke, heart failure or pulmonary hypertension, end-stage liver disease, end-stage renal disease, COPD or ILD, or neurodegenerative conditions, ALS, or dementia. Palliative care does three things for patients who have serious illness. It manages symptoms. And many of you think about this because you might say, oh yeah, palliative care, you're the pain people, right? You opioids. And we do opioid, we do pain, we do dyspnea, things that you might think of. We also take care of symptoms you might not even imagine, right? Hiccups are a symptom that we have to manage in palliative care. Cough, fatigue, insomnia. We also provide support. That's social support, psychological support, and spiritual support through an interdisciplinary team. And we're experts in communication. So that's delivering serious news, advanced care planning, navigating conflicts between care teams and patients, and also complex medical decision-making. So the traditional view of how we take care of people with serious illness is on the left. People get disease-directed therapy until they reach the end of life and they get some sort of end-of-life care all of a sudden. And the modern view is that disease-directed therapy and palliative care are going on concurrently, and the intensity of them will vary over time. And probably it's not this straight line where palliative care increases and disease-directed therapy decreases. It probably is a little bit more sinusoidal. And at the end of that is hospice, which is a specific part of palliative care and also a specific Medicaid benefit. Now, the Center to Advance Palliative Care gives this long definition of what palliative care is. And you can read it. But I think the most important thing to remember from it is that it's appropriate at any age and at any stage in a serious illness and can be provided along with curative treatment. And I like to think about palliative care in a little bit of a different way, which I stole from our colleague Corey Ingram of Palliative Care. And so he describes this as the best care possible. And what he says is that the best care possible is when we take all of our available diagnostic and therapeutic technologies and we apply them to the treatment of disease. But we also apply them to the physical, emotional, social, and spiritual conditions that erode quality of life. And we do that informed by a patient's values and in service of a patient's goals. Now, it sounds really nice, right? Lots of things sound nice in healthcare, but why are we going to do it? And there's a short answer and a long answer. The short answer is that palliative care increases patient-centered outcomes and it decreases resource utilization. The long answer is that we're going to look at some of the evidence to support that. And it's just a selected bit of evidence. So we want to look at a large systematic review and meta-analysis of palliative care trials, RCTs. 24 trials, improved composite health-related quality of life of more than 5,000 or 4,500 patients. Reduced symptom burden in 29 trials, more than 10,000 patients. Now we think about this being true, especially in conditions like cancer, right? That's true. If we look at a Cochrane review from 2017, looking specifically at early palliative care and advanced cancer in more than 1,600 patients overall, but in over 1,000 patients for each of these outcomes, there's improved health-related quality of life and reduced symptom intensity. But this is true in other disease states too. So in RCT, the PAL-HF trial that was in the Journal of the American College of Cardiology showed that patients with advanced CHF who had a palliative care intervention had improved quality of life in 6 months, decreased depression, decreased anxiety, improved spiritual well-being. It's true in lung disease. An RCT looking at palliative care in both patients with malignant and non-malignant lung disease trial the interdisciplinary breathlessness clinic, palliative care, pulmonology, occupational and physical therapy combined compared to usual care. There was an improvement in breathlessness for everybody, and there was improvement in survival with patients who had COPD and those with ILD, so the non-malignant lung diseases. Does that surprise anybody that there might be improvement in survival with palliative care? Because that's kind of not the whole Grim Reaper in a white coat. Well, this was something that came up in one of the landmark palliative care trials, which was a New England Journal trial from 2010, looking at early palliative care and metastatic non-small cell lung cancer versus usual care. Not only did palliative care interventions improve quality of life, not only was there less depression, better documentation of resuscitation preferences, less aggressive end-of-life care, which the way they defined it really meant less non-beneficial care at the end of life. There was also increased survival, a median difference of 2.7 months, which is really significant if in both groups your survival is less than a year. Kind of hard to get your mind around how palliative care could cause people to live longer, right? I think of it in a couple of ways. One, if you treat people's symptoms and you help them feel better, they might be able to continue with beneficial disease-directed therapy for longer. The second thing is, in some disease states like cancer, the medications that we're giving are poisons, and we're hoping the benefits of the poison is outweighing the downsides of the poison. But as people get sicker, that balance tips, and people will start to get all the negatives of chemotherapy without benefits. And when you stop them, their function and their symptoms can improve, and they may actually live a little bit longer. Now, I would never use any of this to tell a patient that palliative care will make you live longer. But what I would do is say, it's pretty convincing that palliative care does not shorten your life. Now, you might be somebody who is less interested in the patient-centered outcomes, more interested in what does this mean for the health system, right? Big picture thinkers. Well, we have data on that too. So for spending, if you look at a meta-analysis of pooled financial analyses for hospitalized patients with palliative care, the cost savings, we take all diagnoses of people who had palliative care intervention, was about $3,000. We look at just cancer patients, more than $4,000. If we look at in-hospital mortality, because in-hospital mortality is an important quality metric for health systems in terms of how we get rated and potentially how we get paid, palliative care leads to a decrease in hospital mortality, 34% in one systematic review. Now, there was no difference in length of stay among about 18,000 patients that were pooled in this meta-analysis. But other studies have shown that there potentially is a difference in length of stay. So in the ICU, for example, there's been a systematic review, not a lot of studies in this, and they couldn't do a meta-analysis because there was heterogeneity, but they had 4 studies that looked at ICU admission after palliative care interventions. And there was a mean relative risk reduction of 37%. That's a lot of patients not going to an ICU. There was a mean relative risk reduction of 26% in ICU length of stay for those patients. That's a lot less resources being utilized. And we also know, I skipped the slide here, we also know that if patients get earlier palliative care, it seems that some of these differences are magnified. So getting palliative care early in a hospitalization will further reduce the hospital length of stay than getting it later and reduce costs. So now the question is, how does this apply to the emergency department? And what I'm going to do here is talk about 3 main models of palliative care integration that are explored in the literature and the evidence behind them. And I'm going to be transparent. So there's a pretty robust literature saying that palliative care is effective as a field in improving patient-centered outcomes and hospital outcomes. In emergency medicine, palliative care integrations, it's a young area. There are a few studies. We're just getting data. And so there's a true need for further high-quality evidence, and yet we already have some compelling data. So I would argue that there are 3 main models of ED palliative care integration, and then a couple of other ones that I'll just frame as other. The first is primary palliative care. Have you heard that term before this lecture at all? So it means palliative care provided by non-specialists. So in this case, emergency medicine providers. And that can be things like symptom management, palliative care needs assessment, serious illness communication goals of care. And then there's ED-initiated palliative care. These are palliative care interventions that are started in the emergency department, either an order is placed or there's a trigger, whether or not they're actually carried out in the emergency department, but they're not done by the emergency physician. The trigger may be, but not actually the palliative care intervention. And then there's ED-embedded palliative care. And this is where you have a specialty palliative care clinician, a physician or an advanced practice provider who is stationed in the emergency department, providing consults in the emergency department. And the analogy here is our cardiology consulting service, right? They are physically down here, able to do consults. And then those other ones include things like palliative care prior to inter-hospital transfers and telephone-based palliative care after ED discharge. So to look at primary palliative care first, this is the area where our evidence is weakest. So the main study that's been done has not yet fully been reported, and that's the primer study. And that was done partly here at Mayo. And it's a cluster randomized stepped wedge trial at 29 emergency departments. Mayo is one of the sites, covers about 100,000 visits. And what they did was they provided palliative and end-of-life care education, the staff. They provided serious illness communication training in the form of something called EM Talk. And then they provided technical support through the EMR to kind of trigger palliative goals of care conversations. Has anybody seen the the best practice advisory that pops up whenever you don't want it to, that says this patient doesn't have an advance directive, seems to come up at the wrong time, but that's part of this trial. Now, it hasn't fully been reported, but they have reported at least one outcome in an abstract this year. And there was no decrease in acute care admission rate. Now, I question whether that's the right outcome to be looking at, because there's so many of our patients that no matter what we do, we're not going to change the fact of whether they're admitted acutely or discharged. But it's also really hard to study primary palliative care because it's hard to know, are people actually utilizing the principles? Are they interested in this? Are we selecting patients appropriately? Are we doing it in the wrong patient? So while this study ultimately may or may not turn out to be positive, and this part of it isn't positive, I'd say there's still really an absence of evidence here. And the important thing to remember is primary palliative care exists really because there's no one else there to do it. We've got to do palliative care in the emergency department.
So the primary outcome of the study, that's what it was powered for.
So this is one of the primary outcomes of the study. Yeah. So we have to do this because we are the ones here. The question is, how much do we have to do it? And that's why we're going to look at some other models. Sorry, barriers first. The barriers to this primary palliative care are time, interruptions, right? It is not the expectation that we have a 45-minute or a 60-minute conversation with somebody in the emergency department, but even getting 10 or 15 minutes at a time without interruption can be really challenging in our work environment. There's prognostic uncertainty. If you have patients who are seriously ill and you're like, yeah, they're seriously ill, but I actually don't know what's next for them. A lot of us feel that way. The patient who has metastatic cancer, who's on chemotherapy, who comes in, has progression of disease on their CT scan. We don't actually know, did they get an adequate trial of their last cancer-directed therapy? Sometimes it's too early to say, so progression doesn't mean anything. Is the oncologist going to offer a different treatment? We often don't have those answers. And then there's lack of continuity, right? We're not going to see this patient again, and we didn't see them before, so we haven't had these conversations that we can build on. So there are a lot of challenges to primary palliative care, and it's why it shouldn't be our only tool in the emergency department. The next thing we're going to talk about is ED-initiated palliative care. And there's more evidence here. So Rita Grinzen, who did the primer study, was doing it, did an RCT comparing ED-initiated palliative care consult versus usual care in patients with advanced cancer. And the primary outcome was quality of life at 12 weeks. Showed a trend at 6 weeks, and by 12 weeks, there was statistically significant improvement in quality of life and clinically significant improvement in quality of life. A really important study on ED-triggered palliative care is a cohort study from 2021 comparing triggered ED palliative care to match inpatient cohorts. So when they created this trigger, they used end-stage illness, functional limitation, and no to the modified surprise question. Has everybody heard of the surprise question before? Surprise question is, would you be surprised if this patient died within a year? The modified surprise question is, would you be surprised if this patient died during this hospitalization? You've seen a lot of patients in our emergency department who would meet this trigger. To me, a ton would meet this trigger. And if patients triggered positive, they would have a palliative care consult placed by the ED, but it would be done routinely. So for the most part, it would be done on the floor. And what they found was that ED consults more than doubled, and they didn't change the previous annualized growth rate of total consults for the hospital. And there was no increase in ED length of stay compared to the inpatient consults, which makes sense because most of the work is being done on the floor. And importantly, the length of stay for these patients was significantly less. So in patients who were discharged alive from the hospital, median length of stay in the patients who had ED-triggered consults compared to those who were the matched cohort of floor or ICU consult was 4 days less. In patients who died in the hospital, it was 5.5 to 6.5 days less in the ED-triggered consult. That's really substantial in terms of the utilization of hospital resources. And it translates to cost as well. But one other thing I want to mention about this decreased length of stay is that much of the time that was saved is because the consult went in earlier, but they also found that the time from consult to discharge was a day less in the triggered consults compared to the floor and 2.5 days less in the triggered consults compared to the ICU. So just getting the consult earlier seems to speed up the entire disposition process. And cost is also quite different. So there was a cost avoidance of about $9,000 per patient compared to the floor and $15,000 per patient compared to the ICU. And the thing that I really want to highlight here is that this was achieved without any increase in resources at all. Use the existing palliative care team, Palliative care team didn't actually work harder, and we captured the same patients who were already getting consults. Now, there are some barriers here too. So the capacity of palliative care consult services. So they designed that last study to avoid increasing the total volume of consults because the team didn't want to be overwhelmed. And so if we just have ways of the ED placing consults, potentially it's more than the inpatient team can perform, and then it doesn't help anybody. They're potentially inappropriate consults. If you don't come up with a really good trigger or really good criteria, you could be having palliative care consults on patients who don't need them at all. That's a waste of resources. And lastly, there's institutional culture. And I bring this up because at Mayo, this is not a place where people place consults in the emergency department that are seen on the floor. And there's a concern about how this will be taken by primary team. There's also a concern about the relationship that palliative care is built with primary teams, and this could undermine it. So for something like this to work, it takes some really strategic change management. Now let's talk about ED embedded palliative care, because this is where a lot of the work is being done now. There's a lot of attention on this. So there was a study by Newgarden in academic emergency medicine in 2023, and it was a quasi-experimental study compared ED embedded consultations to matched inpatient consultation. They found that by having that provider, that specialty palliative care provider in the emergency department, they increased total consult volume in the ED more than 5 times compared to the prior 12 months. And they found that hospital length of stay was again significantly shorter. So it was a reduction of about 5 days. Now, there were some differences in terms of groups in terms of mortality rates, so that may have affected that. They also found that ED length of stay was longer in this study, but they measured that as door to depart time. And so it wasn't door to admission time. And they were doing this in the midst of COVID. So at least they hypothesized it was potentially because the patients who got the consults in the ED were the ones who were already waiting longer because they were boarding compared to the patients who went up to the floor faster and they may have gotten an inpatient consult. But we don't really know the effect on length of stay. And then that same duo who did the ED triggered consult study did a similar study looking at ED embedded consultations to a matched inpatient cohort. And in their case, they increased ED consults by 10 times compared to the prior 12 months. And they wanted to generate more palliative care consults overall. And they were effective in doing this, more than doubling the consult volume. They found no increase in ED length of stay compared to 4 ICU consults. And again, they matched those ED embedded consults to a group of ICU and floor consults. And they found that length of stay was significantly less, again, 8 days shorter than the floor and 4 days shorter than the ICU. They also found that there were some patient-centered outcomes that were important. So there were changes in care. 11% avoided the ICU compared to what they were planned for before they had the consult. 11% avoided admission, 50% change in code status. They're really dramatic changes for having an ED consult. And cost, and in this case, it's not cost avoidance, it's cost savings. So they averaged the cost savings by the proportion of patients who get ICU consults versus floor consults. And they discounted to account for loss of revenue. And they found that every ED embedded consult saves about $5,700. And the return on investment for the cost of having that ED embedded provider is about 6.7 times. And that return on investment will go up for hospital systems that rely more on value. So there are a lot of benefits to the health system and a lot of savings in terms of resources and costs that come from ED embedded palliative care. Now there are barriers too. The first is palliative care workforce. There are not enough palliative care doctors in the country right now. There are more retiring than are being trained. Residents, if you want job security, go do a palliative care fellowship. And it's projected to continue until 2040. So you have to be really strategic about, do you place somebody dedicated into the emergency department? The hours of coverage. In these studies, the hours of coverage was either 11 a.m. to 6 p.m. or 11 a.m. to 7 p.m. in one study 3 to 5 days a week and another 7 days a week. It's not going to be 24/7 under any circumstances because there aren't palliative care doctors who are going to work overnight. And except for me. ED length of stay. I think this is something that the evidence we have doesn't necessarily give us a clear answer, but we've had the experience with Sapphire for all its benefits that it does sometimes increase how long somebody's in the emergency department. So we just have to be mindful of it and think about it. And then the necessity of consults. Once you sit somebody in the emergency department and say, look for some business, they're going to find business one way or another. Now, some of that business doesn't need to be found in the emergency department. It doesn't require acute, urgent, or emergent palliative care consultation, and that's not really a good use of resources. It doesn't benefit patients or the system. And then the other approaches that I want to touch on. The first is telemedicine goals of care for patients being transferred to a referral center. So this is patients who are in a community emergency department. And Pittsburgh, similar to Mayo, has University of Pittsburgh has a health system associated with it. And one of my faculty members in fellowship started a pilot where if a patient was at a community emergency department and they were being admitted to a referral center NICU, they would run a scoring tool with an algorithm called SafeNet. Think about, are they actually going to have a good outcome or not? Is there going to be benefit to this transfer? And if it was high risk to not have benefit, then it would trigger a conversation between the community emergency provider, the receiving hospital intensivist, and a palliative care provider. They would agree on prognosis, and then the palliative care provider would go in on the video screen that we use for telestroke and have a goals of care conversation. And the reason this is important is because all of us have seen patients sent for Rochester care, medical or surgical, who get here and it's not offered. And then they're hours away from home and they're too sick to get back. So it's important to be thoughtful about this. Now, there's not data on this, they're collecting it. But I think it's a really interesting idea and it kind of has some base validity. And the studies would show that patients who get transferred from EDs to other hospitals typically never have goals of care conversations. The other approach to bring up is nurse-led telephonic palliative care, and this is being studied in something called the Emergency Medicine Palliative Care Access Trial. Currently, we don't have the data on this, but what they look at is patients who are being discharged from the emergency department with a palliative care need. So the ED provider says, you're pretty sick, you don't need to come in the hospital, I'm worried about what the future looks like, or you have symptoms that need to be addressed, and you can't get patients into outpatient palliative care clinics because there's not capacity. So what they did was they had nurses who were specially trained and then working in conjunction with physicians have telephonic follow-up to provide palliative care services to patients who are discharged from the emergency department. They're comparing those outcomes to patients who got care in an outpatient palliative care clinic. So this is kind of the range of models that we can use for integrating palliative care into the ED. And so the next thing is to talk about the vision, because we don't have this system built up yet. But in my vision, we're going to have to say, how do we put these models together without overburdening our staff? And I think it's going to be multimodal, involving all of these different approaches. And it's also really going to depend on patient selection. We need to get the right care for the right patient at the right time. So I would say that there are 5 categories of patients with serious illness that we see in the ED. Those who are admitted to the floor, they're pretty stable. We're not that worried about them, but they're coming in. And, this would be that patient who has metastatic cancer, has progression of disease, maybe has failure to thrive, hemodynamically stable. They're the patients with uncontrolled symptoms. We certainly see these patients. There are patients who are discharging with palliative care needs. Maybe the patient who has advanced dementia and is coming in and has recurrent UTIs. Those pending transfer to a referral center, so those patients in a community emergency department, and patients with critical illness or unclear disposition. And I'd say that in 4 out of 5 of these categories, most of the work shouldn't be on the individual ED provider. It should be a systems approach. So let's look at the patients admitted to the floor. So what we should do for these patients who are stable, who are going to the floor, who have serious illness, who we think require further conversation about that or palliative care assessment, we should just make sure that we're screening for code status. We should know strong wishes that are already there. Maybe that means looking for their documentation, or maybe and confirming it with them, or just asking them about it. We should also be doing early identification. So expressing worry about what might happen and forecasting the need for a conversation. So a patient who has their 4th or 5th admission or aspiration pneumonias in the last 6 months, it might be helpful to say, I'm really worried that this pattern of being in and out of the hospital every few weeks is going to continue. because we already know that is going to, and that means it's really important that we talk during this hospitalization about what's important to you. And what the system should do for these patients is we should make sure that we have a system to do ED-initiated consults, move these consults upstream, trigger consults if we can identify admission triggers that are appropriate, AI identification of at-risk patients. They're already doing this on the floor, looking at patients who are expected to have a palliative care consult based on an AI algorithm, and it shows that there is a 25% reduction in 60 and 90-day readmissions to the hospital. We'd have to figure out how to do that for patients in the ED, which is its own challenge, but it's something to consider. And then if we have the resources and we can justify it, we should have embedded palliative care. Now, if we take those patients who have uncontrolled symptoms, we see these patients a lot, don't we? Pain crises, nausea, severe constipation, agitation. What we should do is continue to treat them aggressively the way that we do. We're actually better than a lot of our colleagues on the floor at treating acute symptoms. We use doses of opioids that are more appropriate, more comfortable with that dosing. We use a broader range of antiemetics. And we can always improve, and there are things that we can learn, do better, but we already do pretty well. And then we should rely on our on-call palliative care by phone because they're there. That's what they're there for, 24 hours a day. If there's a symptom crisis, it's the perfect time to call and get advice over the phone. It's usually easy for a palliative care provider to give. What the system should do, well, we can build in some tools that can help make it easier for us, leveraging the EMR. So at University of California, San Diego, they utilize the EMR to have patients who are on chronic opioids, calculate the OME, and then propose the clinician an appropriate opioid dose for patients who are in a pain crisis. So you don't have to do your opioid calculation. Seems like it makes sense. Those patients who are discharging with palliative care needs, right? These are a lot of patients that we see. Somebody who has frailty, who keeps falling. Maybe they fell and have a distal radius, but they are ambulatory. They can go back to their facility or their assisted living. What we should do is be those early identifiers. We want to express worry and forecast the need for a conversation. We don't necessarily have to have this conversation emergently in the emergency department, take up a ton of time, especially when it's something that may have to occur over multiple visits. What the system should do is develop a pathway to outpatient palliative care, right? We don't have the ability to place those orders right now because there isn't the capacity, but if we could have appropriate patient identification, we could say this narrow group of patient can get an outpatient palliative care order. We can create a process for streamlined referrals to PCPs for goals of care from the ED. Because if you put in a post-ED follow-up order, they're going to be put into a 15-minute slot with a primary care provider who has opening on their calendar, not with their PCP who knows them. And it's not going to be the 45 minutes to an hour. And they're going to be thinking they need to follow up on the medical issues from the ED visit. We want them to have the time and the knowledge that there needs to be a conversation about goals. And then we should pilot novel strategies like nurse-led telephonic palliative care. If it saves resources, that would be a great way to discharge a patient and say, we're worried about you. We're going to have someone call you to talk about what's important so you can get the care you need. Those patients who are pending transfer to a referral center, that's exactly what I talked about in that pilot initiative in Pittsburgh. We've identified patients at a high risk of an outcome. A patient who has metastatic cancer, not on chemotherapy, who is in septic shock, is unlikely to benefit from the MICU here. And we should attempt goals of care conversations. And I say that because it's the ideal thing to do, but also with the knowledge that a community emergency medicine provider and single coverage, or who doesn't have a learner and has 10 or 20 rooms they're covering, spending the time having a goals of care conversation is a big lift. It's really challenging. And so what the system needs to do is implement the prognostic screening. And when triggered, develop a standardized palliative care process. Now, this is something that has to be negotiated. We have to encourage people to become comfortable with it. But a palliative care provider having a conversation with a patient who's sitting there in Albert Lee, who has metastatic cancer and ischemic limb that the surgeon is not going to intervene on, get the surgeon to talk, the palliative care provider to talk, the local ED provider, and maybe if it fits the goals, we avoid sending the helicopter, we avoid bringing them here, and then having the big challenge of this isn't where they want to be at the end of life. And lastly, critical illness or unclear disposition. And this is the group of patients that we have to own in the emergency department. Dr. Stanich was owning it today throughout her pod. What I mean are patients who meet ICU criteria, who need an emergent procedure, who are borderline for the floor, or unclear disposition, obviously borderline for the floor, or borderline for discharge, or requesting discharge against advice. And we want to clarify a little bit about why. What we need to do is primary palliative care. We need to assess their ACP documentation, their advanced care planning documentation, know what it says. We have to deliver serious news. We have to tell them what's going on in a way that they can understand it. We have to understand their function and their values. This is something that Dr. Stanich emphasizes all the time. You have to know what they were able to do yesterday. That's the best it's going to get. And we have to make a recommendation. So talking about goals of care is like the only time we're ever like, what do you want? Right? We don't say that when somebody comes in and they have low back pain. We're like, what kind of pain medication do you want? We've got ketamine and we've got Dilaudid. And we have to make a recommendation based on our medical expertise. And what the system needs to do is we have a palliative care consultation by phone. They're really complex cases that may be somebody that we talk about. Many times in those cases, we're not going to figure that out in the emergency department anyway, if we're calling them. Now, in order to do that take care of that last group of patients, we need to have some skills. And so the last part of this talk, I'm going to leave you with 5 skills in primary palliative care to take to your next shift. And hopefully, as we build a system that cares for patients, you're still applying those to these patients with critical illness and unclear dispositions. So the first thing is to identify and interpret advanced care planning documents. This is a recurrent issue in the hospital. It's come up multiple times in the emergency department. There was an MDR a month ago about this. We need to look. So the first thing to do is you go on to the storyboard and you hover over the code status and things pop up, or you click on it. I just learned about hovering like 2 weeks ago, and it's great. And it's actually better because when you hover, this will pop up. And I apologize that on the Epic Playground, nobody actually has any advanced care planning documents to make this look real. But that advanced care planning.
Actually, it's very real.
The advanced care planning document section of that will be visible. And if there's a post, it'll actually say that it's a post. And if it's an advanced directive, it will say it's an advanced directive. And you can also see their code status history and their advanced care planning notes as well. And if you click on it, you'll get this long page with emergency contacts or healthcare agents at the top, the scanned documents or filed advanced directives. You really want to look at those scanned documents and you'll find if there's something there, they'll say advanced directive no matter what it is, whether it's an advanced directive, a pulse, the healthcare power of attorney, but you have to click on it to open it and see. But that's where it's going to be. And as you scroll down, you'll find previous code statuses. Just to remind everybody, a previous code status is only valid during the encounter in which it was ordered. So you can't say, oh, they were DNR last time, they're DNR this time. It's a really important piece of context, and you shouldn't ignore it. But you have to put it together in the picture. And then advanced care planning notes at the bottom. It's also where you can create advanced care planning notes. This is getting less and less relevant over time, but there still may be pre-Epic documentation in the document viewer. So if you click on that, you might find advanced directives. Now, the really important thing to know how to do is interpret a pulse. That's what we have to be fast on. And to compare a pulse to an advanced directive is of patients of any age and health. It typically consists of a healthcare power of attorney and a living will, provides values and wishes for a hypothetical future state of health. And it's written in vague legalese. It usually doesn't say what to do in a way that is clear and rarely useful in an emergency. That's why the PULSE form was developed for patients with serious illness or frailty only. For those patients for whom you would answer no to that surprise question, would you be surprised if they died in a year? Other patients are not candidates for the PULSE. It's a standing portable medical order, so it can be followed by EMS or an emergency department. In Minnesota, it must be signed by a physician or an APP, and ideally it's going to be signed by a patient or a surrogate. And you can follow it in an emergency. And this is what it looks like. You've all seen them, but sometimes it's kind of confusing about like, what does it actually mean? All there is box A is if they're in cardiac arrest, they do not have a pulse. It's either attempt or do not attempt CPR. If they have a pulse, you go to box B, full treatment, all interventions, including intubation. Comfort-focused treatment is comfort-focused treatment, right? not life prolongation. Selective treatment gets people tripped up because it has all of this stuff written there. The only thing that matters is do not intubate. It says generally avoid the ICU. I haven't met many patients where I'm saying, generally I do this and that's what I'm doing. It doesn't mean anything to me. How do you interpret generally? So I would say it's all care apart from intubation. And what's important is these are the things we need to know emergently, and then we can clarify any other interventions. Sometimes it's hard to know in which patients do I look at the pulse, in which patients do I look at other things. I made this little flow chart, which you may or may not find helpful. But the first question is the patient an extremis? If they're not, whether they have decisional capacity or not, you're going to look at advanced care planning documents for context. You're going to have a goals of care discussion either with the patient or with their surrogate, and can't reach the surrogate. You're going to keep trying because there's time. In the patient who's in extremis, the question is whether they have decisional capacity or a surrogate immediately available. If they do, you're going to have a rapid goals of care code status discussion with them and reviewing those advanced care planning documents for context. So if they have a pulse, you're going to look at that pulse and you're going to reflect it to them. This is what this document said. We are always going to ask a patient to weigh in if they have the capacity to do it. But if they're an extremis, they don't have decisional capacity and there's no surrogate available, and they have a pulse, then we think it's valid, you just follow it. You're protected in doing so. The second tip is knowing your prognostic tools. Most of the time, the emergent decisions we have to make are around CPR and intubation. So on the left, there's a QR code for something called the GOFAR calculator, which is a validated tool that predicts the likelihood of good neurologic outcome in a patient with an in-hospital cardiac arrest. And in all patients in hospital cardiac arrest, about 1 in 5 will survive to hospital discharge, but it can vary pretty widely based on age and comorbidity. This helps you understand that before you have that code status discussion with them. One thing to note is the study defined good neurologic outcome as a cerebral performance category of 1, which is better than what we usually do for neurologic outcomes. So I wouldn't use the exact number. I would use it as context for the conversation. The second QR code is a paper on emergent intubation in older adults and a shared decision-making tool. So if we take older adults who are intubated emergently for any reason, in the patients who are 65 to 74, about a third will go home, a third will be discharged to a nursing home, and a third will die in the hospital. But as you go up in age, it changes. By the time someone's 90, they have a 50% mortality in the hospital if they've been intubated for any emergent condition. Again, this is helpful for informing those conversations. The third tip is responding to emotion. So I've heard from many colleagues, from learners, that one of the hard things about having goals of care conversations is people get upset. And then we feel like we hurt them because we said something and now they're upset. A patient or a family member showing emotion is actually a sign that you're doing your job, that you're communicating the severity of illness. And we have to be able to respond to that with skill, both because it's the empathic thing to do, also because it allows you to move forward with a conversation. People who are emotional have a hard time then thinking about other things. So we use a mnemonic called NURSE in palliative care to describe types of statements to respond to emotion. And so there are things called naming statements. All you're doing is naming the emotion you're seeing, and you say something like, this is overwhelming. It validates what someone's experiencing. Understanding statements, we never, ever, ever say to people that we understand what they're going through because we will always be wrong. But I kind of flip it on its head. An example would be, I can only try to imagine what this has been like, right? But it's showing you're attempting empathy with them. Respect statements. This is acknowledging the identity of a patient or a family member. So you have a family member of a critically ill patient who keeps asking about every detail, every number on the monitor, right? That's probably actually an emotional response. And we should acknowledge them for what they are. You're an incredible advocate. You're really catching all of these things. Support statements. This is helping patients know they're not going to be abandoned. They're dying in the emergency department. We want to say our team is going to help you through this, help the family through this. We don't want to promise things we can't do. So in the emergency department, this is a little bit more nuanced because they might not stay down here forever. And then lastly, if a patient expresses a emotion and you're not sure what it is, or somebody says something and you don't know what it means, you explore it and you just say, tell me more. People will tell you, but it is amazing how this will de-escalate emotions for many patients, many family members, and then allow you to move forward in a goals of care conversation. 4 tips. I want you to avoid these 2 words, want and need. This is how a lot of code status discussions go in this hospital. You want us to restart your heart? Yes, but this is what people say. Of course I want you to restart my heart. That's not really what we're asking, right? We're asking, do you want us to attempt a procedure that has a fairly low likelihood of success and entails many other things? And if successful, you still may have disability. We also want to avoid saying need. Really common, somebody says, your mother needs a breathing tube. Do you want us to do that? There's cognitive dissonance in having somebody in authority say that someone needs something and then asking, do you want it? Because how are they going to say no? So instead, what we want to do is value-based decision-making. We take the medical information and the values, we put them together, and we give a recommendation. So we're using our expertise, and a recommendation is not telling them what the plan is. People can disagree with a recommendation. You take your car and they always give you a list of things to fix, and you never fix all of them, right? You fix 2 of them. So we all know how to disagree with recommendations. And the way to have value-based decision-making is to use a conversation guide. There are 2 QR codes. The one on the left is the Serious Illness Conversation Guide made by Ariadne Labs at Harvard. It's widely used. It's used at Mayo in order to walk you through the conversation, give you the exact language in the order that you need. And the one on the right is an adaptation of this for the ED by Koichi and his team. Now, the reason that we need a guide is because communication is a procedure. And like any procedure, there are certain steps that need to be done in order to have success. Here's the example of the Serious Illness Conversation Guide. It's not designed specifically for the ED, but it's adaptable and it covers the important aspects, right? Asking permission, delivering a warning shot, delivering a prognostic headline, exploring values, and making a recommendation. It's only 1 page. You can print it out. You can bring it into the room as you're having a conversation, and you can read the exact wording off of it. You don't have to be perfect to have a good value-based goals of care conversation and make a recommendation. So I encourage you to use this. So it will make this job easier. So those are the tips. And that'll take me to the conclusions, and I'll be quick in wrapping this up. So what I hope that you take away overall is that palliative care is beneficial for patients and for health systems, including when it's integrated in the emergency department. And that the ideal model of emergency medicine palliative care integration will be multimodal and tailored to the patient. We need to build a system with these different approaches to care for different patients. Palliative care integration can and should minimally burden emergency medicine providers. We really own those patients who are critically ill or unclear dispositions, but the rest of the time, we need to have a system that cares for these patients. And lastly, you need to have primary palliative care skills to apply to patients who are critically ill and those with unclear dispositions. I have plenty of references that I can share with you if you'd like them, and appreciate your time, and I'm open to any questions.
Alex, thank you very much for this fantastic talk. I feel as though all of the examples of suboptimal practices that you mentioned must have come from watching me specifically. And I'm really excited to work on incorporating these new strategies. To everyone listening around the world, thank you for tuning in to our show. I hope you found this helpful and will be thinking about how you can partner with palliative care in your facility or your hospital, and how you can use palliative care principles in your practice on the very next shift. Even if a specific Mayo Clinic solution isn't built in your shop already, the idea can be a springboard for you and your teams to create your own solutions, or for you to find solutions that are already built in your environment. As always, thank you for listening to our show. And don't be a fool. Come back April 1st for the next chapter of Always on EM.
The Always on EM podcast.
Emergency Medicine Grand Rounds.